Good afternoon, everyone. Welcome to today's webinar entitled Medicare Advantage 101 for Home Care Agencies. My name is Andrea Martinez, and I'm representing the Home Care Association of America, and we're so glad that you're able to join us for this webinar today. Today's webinar is sponsored by CareAcademy, and we're so glad that they are joining with us to present this important topic. And with that, I'll turn it over to Helen Adiosun with CareAcademy. Helen?
Fantastic. Well, thank you so much, everyone, for joining us. My name is Helen Adiosun. I'm CEO and co-founder of CareAcademy, and I have a very deep felt passion for helping home care agencies grow and empowering caregivers, and really excited about this new trajectory, new opportunity for home care agencies in Medicare Advantage that Tom Barker, friend of CareAcademy, will be talking about today. So just a little bit about Tom, and I always want to mention, because this is a hot topic and everyone is really excited about it, we will definitely be recording the webinar. We'll mention that again, but we will be recording the webinar and we'll be sending that out, and you can also access that at careacademy.com. So Thomas Barker is a partner at Foley Hoag who focuses his practice on federal and state healthcare legal and regulatory matters, with a special expertise in Medicare and Medicaid law. In May of 2019, he was appointed as a commissioner of the Medicaid and CHIP Payment and Access Commission, or MACPAC, an advisory body that provides policy advice to Congress and the states on the Medicaid and CHIP programs. Prior to joining the firm, he was acting general counsel of the U.S. Department of Health and Human Services and general counters for the Centers for Medicare and Medicaid Services. So very excited to have Tom's expertise today. He's a friend of CareAcademy and regularly advises our team as well. And so with that, Tom, I'll let you take it away.
Thank you, Helen, and good afternoon, everyone, or good morning to those of you joining from the West Coast. My name is Tom Barker, and I appreciate the opportunity to speak to you today. I'm going to run through a slide deck and hopefully cover the following topics. So first of all, I want to give a little bit of a history of the Medicare Advantage or the MA program, then talk about the growth and prevalence of the program, say a little bit about the requirements for Medicare Advantage benefit design, talk about payment to Medicare Advantage plans, and then the main focus of today's webinar, what's new with home health and Medicare Advantage, and in particular, I'm going to talk about liberalization of CMS's rules regarding supplemental benefits, and also talk about an executive order that the president signed earlier this month. I'll also say that we will have hopefully plenty of opportunity for Q&A, both during the presentation. If people want to type in questions, I have access to them, and I'll see them here. If you want to use the chat feature, or at the end of the webinar, we'll open it up for questions. And my contact info will be on the last slide, and so I'm happy to answer any questions if people want to follow up with me. So with that, let's kick off the program and start off by talking about a history of the history of the Medicare Advantage program. So I guess I'll start off by saying that the traditional Medicare fee-for-service program has and really continues to be the predominant way that Medicare is paid for in the United States. That being said, private health plans have been a part of Medicare since the program was established in 1966. President Johnson signed Medicare into law in August of 1965, and the program took effect about 5 months later in January of '66. And even though the government is the traditional and predominant payer for Medicare, and that has been the case for the past 50 years, and it is still the case, private health plans have been a part of the program since its inception. And as we will see as our webinar continues, the growth of private health plans has really continued significantly, and it really took off in 2003, 2004 in that area. The reason that Medicare really began to include private health plans, and it was traditionally and typically HMOs, the reason was that retirees who were aging into Medicare, who had employer-sponsored insurance, wanted an opportunity to be able to retain their existing patient-provider relationships. And so Congress felt that it was appropriate for Medicare beneficiaries to, if they wanted to, retain a private health option. In 1972, and then 10 years later, in 1982, Congress expanded the use of private health plans, and it also moved plans away from the way that they were being paid traditionally based on reasonable costs to what is called the capitated payment system, which essentially means that Medicare pays health plans on a per member per month basis for every enrollee. And that has been the case pretty much since 1982. Over the past 15 to 20 years, Congress has changed the payment methodology, but it still retains that capitated feature of a per member per month payment system. So let's move on now to a little bit further discussion about the history of the program. So I mentioned that really from the inception of the program, there was a private health option, but along about 1997, so 35-ish years after, or I guess 30 years after Medicare was created, Congress decided that it really wanted to create more opportunities for Medicare beneficiaries to have private health options. And so Congress and the Clinton administration agreed, as part of the Balanced Budget Act of 1997, that there would be a new program called Medicare Part C, that it was at the time called the Medicare Plus Choice Program. And that gave an opportunity for new private plan options for Medicare beneficiaries that pretty much resembles the Medicare Advantage program that exists today. The genesis for that program really was the BBA in 1997. It created a new payment formula. Again, it still retains the feature of a per member per month capitated payment system, but it created a new payment formula that allowed plans, or it gave plans different payment amounts based on the health status of their enrollees and also based on the location of the enrollees. It also created new private plan options so that the beneficiaries weren't limited to just being in an HMO, but beneficiaries also had a choice to be in a preferred provider organization or a PPO, a physician-sponsored organization or a PSO, private fee-for-service plans, and also a new high-deductible health plan option. So the whole purpose of the Medicare Plus Choice program in 1997 was to try to give beneficiaries more options. And at the time, Congress and the Clinton administration both felt that this was an important option for beneficiaries. But what we saw was that despite the creation of this new program in 1997, enrollment pretty much remained low. And not only that, not only did enrollment in the program remain low, but shortly after President Clinton signed it into law, enrollment sort of started to decline in the late 90s and early 2000s. And so we'll go on now and say a little bit more about what happened next. So what happened next was, because enrollment started to decline in the early 2000s, Congress stepped in again, and at this point, George W. Bush was the president, and Congress and the Bush administration agreed on legislation called the Medicare Modernization Act, or the MMA, and that gave the Medicare Plus Choice program its new name, Medicare Advantage. The MMA also created yet another payment structure. Again, it retained the concept of capitated payments, but it created a much more complicated bidding structure. So and I'll say more about this in a couple of slides, but it essentially created the current benchmark framework competitive bidding process that Medicare Advantage plans use now, 15, 16 years later, to set payment rates for the program. And the one thing that the Medicare Advantage, that the MMA program statute did, was really to create the basis for an explosion in Medicare Advantage enrollment. So just by way of example, in 2003, only 5.3 million Medicare beneficiaries were enrolled in an MA plan. So it was about 12% of Medicare Advantage enrollees. By this year, 20.4 million Medicare beneficiaries are enrolled in an MA plan, and that is about a third of the Medicare population. And when the Medicare Advantage numbers are next released, which is going to be any day now, I'm actually sort of surprised that they have not come out already, because they usually come out in October. But I anticipate that when the enrollment numbers are next released, the number of MA enrollees is going to be over 40%. And so the numbers are really continuing to grow. And the next few slides, if we can just go on to the next couple of slides, in the next few slides, you can see the number of beneficiaries enrolled. So you see in the midpoint between 97 and 98, so August of 97 is when President Clinton signed the BBA into law. There were 5.4 prior to his signing the BBA. There were 5.4 million Medicare beneficiaries enrolled in private plans. That number went up to 6.4 after President Clinton signed it, and then you can see that it ticked up, but then it slowly started to tick back down. So then the next data point on the x-axis on the slide is when President Bush signed the MMA into law in December of 2003, and then you can see the number of enrollees really significantly started to increase. So then President Obama signed the Affordable Care Act into law in March of 2010, and then you can see that the numbers just continue to increase. Between 2017 and 2018 was the first year that Medicare Advantage enrollment ticked over 20 million. And then the next slide just shows, it's really the same graphic point, but it just shows by way of percentages rather than the raw number of beneficiaries. And the x-axis, again, has the data point of the enactment of the MMA and then the Affordable Care Act. And we can see that last year and again this year, enrollment in Medicare Advantage is about 34%. And as I said, I anticipate that when the numbers are next released, it's going to be over 40%, which really is, at that point, as the numbers go above 40%, it really does begin to be a game changer. So let's go on to the next slide, and we'll talk a little bit more about where we see Medicare Advantage enrollment. So you take a look at this map of the United States. Not a lot of surprises here, but I do want to just point out a couple of things. So the states in red are those states where Medicare Advantage enrollment is greater than or equal to 40%. So not a lot of surprises. So you see Oregon on the West Coast, you see Minnesota, Wisconsin, all of those states have very high managed care penetration, and they have since the first Managed Care Act was signed into law in the early 1970s. Florida has a significant Medicare Advantage population, and that's just because of the large number of elderly individuals living in Florida. Also, you see Pennsylvania here, which I actually think is maybe more a reflection of the competitive dynamic that is going on, especially in Western Pennsylvania, with two really large payers, both the University of Pittsburgh Medical Center and Highmark, both very, very aggressive marketing of Medicare Advantage plans. And so I think that's why you see those numbers are very high. I also just want to point out Wyoming, 3% enrollment, and I think that's really just more a reflection of the fact that very, very small population in Wyoming, and it's probably I'm guessing that's because it's very difficult for an MA plan to put together a provider network. But these numbers, blue, the darker blue, that's pretty much right around the Medicare Advantage enrollment numbers nationwide, which is again 34%. But again, I think we'll see these numbers start to change as time goes by. So we can go on to the next slide now. I want to talk now about Medicare Advantage, the benefit design of Medicare Advantage. So as I mentioned, Medicare Advantage is an alternative for a Medicare beneficiary once they turn 65. It's an option for Medicare beneficiaries to receive their health benefits through a private health plan rather than through a government-paid health plan. Medicare Advantage is an all-in-one alternative to fee-for-service Medicare, and it essentially bundles together Part A benefits, so institutional services like inpatient hospital services, Part B, physician and other health professional services, and typically Part D, the drug benefit. And it combines all of those into one health plan. As a general rule, this is a statutory requirement. MA plans have to cover all services offered by traditional Medicare. An MA plan cannot choose, for example, not to offer inpatient hospital benefits or to limit hospital stays or to limit physician services or some of the other benefits that traditional Medicare covers, like physical therapy, for example. An MA plan has to cover all services offered by fee-for-service Medicare. But the difference is MA plans are also given the flexibility to offer additional benefits and also to change the cost-sharing structure so that they have different cost-sharing plans or requirements that differ from fee-for-service Medicare. So, for example, unlike in fee-for-service Medicare, Medicare Advantage enrollees typically have to see providers that are in their plan's network and may require referrals to see a specialist. That's not a requirement in fee-for-service Medicare. So in that sense, MA is more restrictive than traditional Medicare. But a Medicare Advantage enrollee also has a PPO option, and they can, if they want, they can enroll in a preferred provider organization plan that allows them to go out of network. But where Medicare Advantage is traditionally more beneficial or more favorable than in traditional Medicare, it's with respect to benefit design when it comes to cost sharing. So, for example, in Medicare Part B, cost sharing is a standard 20% of the Medicare payment amount for example, a physician service. But Medicare Advantage plans do not have to charge 20% copay. For example, an MA plan can say to an enrollee, cost sharing for you for a Part B service is $5 per physician visit or $20 per physician visit. Furthermore, unlike in traditional Medicare, Medicare Advantage plans have a maximum out-of-pocket cap for Part A and Part B covered services. So it will have a catastrophic benefit cap. And importantly, and we'll talk about this on the next slide, importantly, Medicare Advantage plans also allow individuals to obtain supplemental benefits. So we'll talk about that on the next slide. So this chart just sort of shows the difference between traditional Medicare and Medicare Advantage. So in traditional Medicare, it's divided into Part A, Part B, and Part D. Medicare Advantage essentially combines those three into one insurance product. In traditional Medicare, cost sharing is standardized. So, for example, there is a flat deductible for the first day of a hospital stay. There's 20% coinsurance for Part B services. There's coinsurance for skilled nursing facilities, for skilled nursing facility services. MA plans can have a different benefit design and typically have lower out-of-pocket costs than fee-for-service Medicare. In fee-for-service Medicare, there's pretty much free choice of providers, whereas with Medicare Advantage, enrollees typically have to use providers in a plan's network. And then in traditional Medicare, Congress creates the benefit design. Congress creates what the benefits are: hospital services, physician services, physical therapy, outpatient hospital services, psychiatric services, for example. Whereas Medicare Advantage plans can offer, as I was suggesting earlier, can offer extra benefits that fee-for-service Medicare doesn't cover. And those are called supplemental benefits, which I'll say more about in a moment. But just some examples of supplemental benefits that traditional Medicare doesn't cover. So, for example, traditional Medicare doesn't cover vision services. Traditional Medicare will cover a pair of eyeglasses only post-cataract surgery. But if someone wants their vision checked and goes to an ophthalmologist, traditional Medicare will not cover a pair of eyeglasses. Traditional Medicare also doesn't cover hearing services. It doesn't cover dental, whereas a Medicare Advantage plan via supplemental benefits may well cover those services. So let's talk more about how that works, and we'll go on to the next slide to talk about that. The way Medicare Advantage plans are able to offer supplemental benefits is really tied to the way that Medicare Advantage plans are paid by Medicare. So as I mentioned at the very beginning or the very outset of the program, Medicare pays Medicare Advantage plans a capitated per member per month amount. And with that per member per month payment amount, Medicare Advantage plans have to provide all Part A and Part B covered benefits, but it's based upon a bidding process that relies on competition. As I mentioned, the payment methodology has changed over the years to achieve different policy goals. So, for example, the Balanced Budget Act changed the payment design in order to encourage more people to enroll in Medicare managed care, and in particular, it created a payment floor that was designed to encourage enrollment in Medicare, what was then called Medicare Plus Choice, in rural areas of the United States. And then in 2003, the Medicare Modernization Act increased payments to MA plans, and that was just a blatant attempt to encourage more people to enroll in Medicare Advantage and get them out of the fee-for-service program. And it also established the current bidding process, which I'll say more about shortly. And then, because there was a concern that Congress and the Obama administration had in 2010 that Medicare Advantage plans were overpaid, Congress and the Obama administration agreed to reduce payments to MA plans as part of the Affordable Care Act. But as we will see, or as we saw on those earlier slides, enrollment in Medicare Advantage really was not hindered by the reduction in payments, because enrollment in MA continued to tick up in the Obama administration, and it continues to this day. So let's go on to the next slide and say a little bit more about how payments are made. So under the current structure, which has now been in existence for 16 years, since 2003, Medicare Advantage plans essentially are paid based on a bidding process that relies to a large degree on competition. Medicare Advantage plans essentially submit a bid to the Medicare program. An MA plan essentially will say, we anticipate that it is going to cost us X dollars per member per month to provide the standard Part A, Part B benefit package to enrollees in our plan. So let's just, to make the math easy, let's just say that an MA plan decides that it's going to cost $1,000 per member per month. I should point out that Medicare Advantage plans are made on a county-by-county basis, and payments to MA plans are made on a county-by-county basis, and that has been the case since the 1960s, since the Medicare program was created. And there was, ever since there's been a private health plan option, payments are made on a county-by-county basis. So let's just say, to use an example, because I, at the moment, am sitting in Boston, Massachusetts. So let's just say that an MA plan in Suffolk County, Massachusetts, assumes it's going to cost $1,000 per member per month to provide the standard Part A, Part B benefit package to an enrollee. That bid is compared to a benchmark amount that CMS establishes for every county every year. So every county in the United States has a benchmark amount. So let's just say that a plan's bid is higher than a benchmark. In that case, that an enrollee would have to pay the difference between the benchmark and the bid via a monthly premium. But that hardly ever happens. The much more common scenario, 90+% of the time, is that the MA plan bids an amount lower than the benchmark. So again, let's just say in my example that an MA plan submits a bid of $1,000 per enrollee per month. But the benchmark for Suffolk County, Massachusetts, let's say, is $1,200 per member per month. So the way the bidding process works, the plan and the Medicare program split that $200 difference. That $200 difference is essentially rebated to the plan, and the plan can use those rebate dollars to provide supplemental benefits to enrollees. Once all of that math is worked out, then payments to the plan are adjusted based on the risk status or the risk profile of each enrollee. And then one other aspect of the payment system, the Affordable Care Act created a quality measuring system. essentially a star rating system. Each health plan is awarded a certain number of stars that reflects their quality performance, and high-performing MA plans get an additional payment amount in addition to the bid and the difference between the bid and the benchmark. But the key if there's one key takeaway from this slide, it is that the vast majority of MA plans in the United States bid below the benchmark, and because they bid below the benchmark, they get rebate dollars, and those rebate dollars can be used to provide supplemental benefits. And that's what we're going to talk about now. So let's go on to the next slide. I want to say a little bit about home health and Medicare Advantage. So because home health is a required benefit in fee-for-service Medicare, MA plans must cover home health benefits. And home health coverage in Medicare Advantage is generally limited to, as is the case with fee-for-service Medicare. It's limited to part-time or intermittent skilled nursing care, physical therapy, occupational therapy, speech-language pathology services, medical social service, part-time or intermittent home health aid services, so personal hands-on care, generally for a Medicare Advantage or a Medicare enrollee who is homebound. But what Medicare generally will not pay for is 24-hour day care at home, home-delivered meals, homemaker or home care services, custodial or personal care like bathing, dressing, using the bathroom, when that's the only care required by an enrollee. That is not a typical benefit or a traditional benefit that fee-for-service Medicare will not cover. In fact, fee-for-service Medicare is precluded from covering those services. But what we're going to see is that MA plans can use their supplemental benefit authority to provide those services. So coverage for additional home health services can be available through an MA plan via a supplemental benefit. So again, remember that if an MA plan submits a bid that is lower than the benchmark, they get a rebate, and they can use those rebate dollars for supplemental benefits such as vision, dental, and what we're starting to see is a lot more services provided to Medicare beneficiaries in the home. So what's a supplemental benefit? I've used that word now multiple times in this presentation. What exactly is a supplemental benefit? So a supplemental benefit may not be a covered Part A or Part B service. It's got to be something different. It can't be something that's traditionally covered because MA plans have to cover those services. Number two, and this is a key point that I'm going to spend a lot of time talking about in the remainder of the presentation, the item or service must be primarily health related. And then number three, MA plans have to incur a non-zero direct medical cost in providing the benefit, meaning there actually has to be a cost to the MA plan to provide the service. But I want to home in now on this concept of primarily health related, because what we will see is that CMS has reinterpreted that phrase, and that is what has made it more likely that MA plans will start to offer a greater number of supplemental benefits. So let's talk about that by going on to the next slide. So prior to this year, prior to the 2019 plan year, CMS defined the term primarily health related as an item or service that is designed to prevent, cure, or diminish an illness or injury. So it was a pretty restrictive standard, and it meant that an MA plan could not offer an item or service as a supplemental benefit if its primary purpose was daily maintenance. But in what is called the 2019 call letter, I'll say a little bit about what that is in a moment. In the call letter that came out this year and the call letter that came out the year before, CMS has greatly relaxed this policy so that MA plans can offer a range of daily maintenance supplemental benefits. So, for example, adult day care services, palliative care, in-home support services, support for caregivers of enrollees, non-opioid pain management, and home and bathroom safety devices and modifications. So I just want to say what the call letter is. So the call letter is basically a request for proposals that CMS issues. So, for example, And by law, the call letter has to come out the first Monday in February. So in February of 2018, CMS issued the call letter for the 2019 plan year. And in February of this year, CMS issued the call letter for the 2020 plan year. And basically what that call letter is it's a letter to health plans that says, "Dear health plans, hope all is well. We're asking for your interest in being a Medicare Advantage plan sponsor for the next benefit year." But what CMS did in the call letter in 2019 and in this year for the 2020 call letter, they announced that they were going to relax the definition of primarily health related. So just looking at that first bullet up here, what the standard had been was that health related means an item or service designed to prevent, cure, or diminish an illness or injury. CMS announced we are going to relax that standard. And so for 2019 and 2020, they've announced further liberalizations, and it is those liberalizations that have allowed MA plans to offer these additional services that are specified here in this second bullet point. So let's go on to the next slide, and I'll say a little bit more about this now. This next slide basically shows graphically the difference in the old policy and the new policy. So I'm not going to repeat the old policy, but I'll focus on the new policy. So the new policy says that if the item or service is designed to prevent, cure, or diminish an illness or injury, and then what's bolded is new, compensates for physical impairments, acts to ameliorate the functional, psychological impact of injuries or health conditions, or reduces avoidable emergency and healthcare utilization. So three new factors: compensating for physical impairment, ameliorating the functional or psychological impact of injuries or health conditions, or reduces avoidable emergency and healthcare utilization. So you can see that this is a much liberalized definition of primarily health related, and it creates an opportunity for MA plans to offer significant additional benefits as supplemental benefits. So not only did CMS make that change in the last two call letters, Congress also got into the act. And in the Bipartisan Budget Act of 2018, Congress stepped in and even further expanded the types of supplemental benefits that can be offered by an MA plan to individuals who have a chronic medical condition. And I would just point out that CMS estimates that approximately 73% of MA enrollees have one or more chronic conditions. So the fact that Congress stepped in here and created this opportunity for an even further liberalization of supplemental benefits is significant because such a large number of Medicare beneficiaries have a chronic condition. So supplemental benefit for chronically ill enrollees give, as I said, Medicare Advantage plans even greater flexibility as long as the items or services. So here is a new test that is even further liberalized, again, for chronically ill enrollees. If the new items or services have a reasonable expectation of improving or maintaining the health or overall function of the enrollee as it relates to the chronic condition or illness. So that is pretty wide open. That's even wider open than the new definition of primarily health related, because all that has to be the case is that there's a reasonable expectation that the overall function of health or function of the enrollee is going to be maintained as it relates to the chronic condition or illness. So again, I didn't articulate that very well. So let me try again. That the item or service has to have a reasonable expectation of either improving or maintaining the health or the overall function of the enrollee. That, again, is pretty wide open, and that is a further liberalization in addition to CMS's new liberalization of the term primarily health-related. So let's go on to the next slide. As a result of CMS's reinterpretation of primarily health-related, and as So as a result of that reinterpretation, MA plans can now offer as a supplemental benefit in-home support services. And CMS has defined those services as services to assist individuals with disabilities and or medical conditions in performing activities of daily living, and IADLs within the home to compensate for physical impairments, ameliorate the functional psychologic. I mean, this is essentially the definition of primarily, the new definition of primarily health-related. Services have to be provided by individuals licensed by the state to provide personal care services or in a manner that is otherwise consistent with state requirements. So MA plans cannot open up the provision of these benefits to anyone that wants to offer them. There has to be some nexus between licensure by the state or at least consistent with state requirements for the provision of personal care services. So that's a protection for Medicare Advantage enrollees. Let's go on to the next slide. So as I mentioned, supplemental benefits are relatively new, essentially a year and 3/4 old. So again, the first announcement that CMS was going to offer a liberalized definition of primarily health-related came in the call letter from last year and again re-announced this year. So they've been slow to come to market, but they're expected to increase in future years. There was a review by very respected healthcare consultant, Milliman, reviewed supplemental benefit offerings in 2019 and showed, you can see them up here on the slide. So the largest number obviously was in-home support services, but all of these are services that traditional Medicare will not pay for, but Medicare Advantage plans are now offering as supplemental benefits. And one other thing I'll say, it's not on a slide here, but I just want to make this point, because I've actually had meetings with CMS about this, about supplemental benefits. So CMS's relationship is with the plan and not the provider. So CMS traditionally, if a provider wants to offer a supplemental benefit, likely that CMS will not meet with the provider, they'll meet with the plan. And so home health agencies that want to offer supplemental benefits and want to contract or have some type of relationship with the plan really shouldn't be going to CMS. They should be going to a Medicare Advantage plan in their service area and talking to the MA plan about designing some type of supplemental benefit offering that falls into these categories or some other type of benefit that is not necessarily one of the 5 things listed here, but any other type of supplemental benefit that one could argue meets either the liberalized definition of primarily health-related or the definition from the Bipartisan Budget Act for chronically ill enrollees. And so that's just something to keep in mind about CMS's relationship with providers and plans. So I guess the next point that I want to make is that this is clearly a policy-driven agenda by the Trump administration. And it seems pretty clear, even though there probably hasn't been a ton of press attention to this, but it seems pretty clear that the administration has broadly prioritized the growth and the flexibility of the MA program. And to that point, about 3 weeks ago, three and a half weeks ago, President Trump signed an executive order at an adult living community in Florida, and he signed an executive order that was designed or aimed at promoting and growing the MA program. And in that executive order, he ordered CMS to further expand supplemental benefits. The executive order allowed MA supplemental benefits to be passed on to beneficiaries as a financial reward for savings. And also, the executive order announced an interest in bringing parity to fee-for-service and Medicare Advantage payment rates. I'm not really quite sure what that means, and I'm not sure anyone else knows what it means either. I think that there was a little bit of alarm that it might be seen as a way to cut payments to providers. I'm not sure that really is what was intended by that language, but we'll have to see how CMS interprets it. So this executive order is not an independent source of legal authority. Rather, it is a directive to CMS to issue regulations that would implement the requirements of the executive order. We anticipate that there will probably be one more Medicare Advantage policy and technical regulation that gets issued in this administration before the election next November. And so typically Medicare Advantage policy and technical rules come out November, December of a calendar year, and they're typically implemented or finalized in the following year. So I would be on the lookout. I mean, as a healthcare lawyer, I'm certainly going to be on the lookout for a regulation from CMS that is designed to expand Medicare Advantage supplemental benefits pursuant to the executive order. So I'm going to wrap up now, and then we can open it up for questions. I guess my final takeaway points are that, number one, I personally expect that the opportunities for home health as a supplemental benefit in the MA program is going to grow in future years. There are, as a result of the new interpretation of supplemental health benefits and primarily health related, and because of what Congress did in the Bipartisan Budget Act, I think there are multiple opportunities for home health agencies, home health providers to design supplemental benefits in coordination with Medicare Advantage plans in the year ahead. Second takeaway point, given the competitive nature of the MA market, we expect that MA plans are going to increasingly offer expanded home health benefits in order to attract and retain enrollees. Remember a point that I made earlier in this presentation, which is that the whole concept of the Medicare Advantage program keys off of competition, and MA plans have a real interest in ensuring that they attract more enrollees. And one way that they're able to do that is by offering additional benefits as a marketing tool. And just one more point that I'll make about that, the open enrollment period for Medicare Advantage starts in the next month, which means that MA plans will be able to start marketing. And so we will start seeing in the next couple of weeks a lot more TV ads or ads on the internet for Medicare Advantage plans. And I anticipate that we will start seeing additional ads for new supplemental benefits as part of the marketing process. And then my third takeaway point is that I do think this offers opportunities for home health agencies and providers to partner with both regional and national Medicare Advantage plans and creating new lines of business. So with that, my contact info, I believe, I'm sorry. Yes, on this slide, I have my contact info, and my colleague, Ross Margulis, who could not be on the call today, but Ross and I both advise home health agencies and MA plans on supplemental benefits, and here is our contact info. And we also have a blog that you can follow us on that blog. And with that, I'm going to wrap up my prepared remarks.
Awesome. Thank you so much, Thomas. And this is Jen Waldron, the SVP of Sales and Business Development here at CareAcademy. I will just mention a couple things about how CareAcademy can help, and then I will start reading off some of the questions that we've been getting. And thank you so much for chatting all of them in, everybody. So in terms of how CareAcademy can help, outcomes really matter in a value-based care model. And so what we're seeing out there from the CareAcademy side of things is that MA plans are interested in seeing that agencies, non-medical agencies, are producing outcomes, much like they expect of different types of businesses who are on the higher acuity end of the spectrum. CareAcademy's classes have been proven to improve the outcome of caregiver confidence in preventing falls. And that was actually published in a abstract in the American Journal of Geriatrics. So happy to send that to anybody who's interested in learning about how CareAcademy is impacting the outcomes of what caregivers learn and then the care that they in turn provide for your clients. In addition to that, some of you may or may not know, CareAcademy is a preferred training provider for ClearCare customers. ClearCare was able to partner with Amedisys to become part of the care coordination network. via the ClearCare platform, you may have the opportunity to be referred personal care business by a Medicist who is a home health provider. And so you can learn more about that. We have a link to it, and when we certainly when we send out the recording to everybody, you can access that. So with that, those are a couple of the ways that CareAcademy can help. I'd love to go ahead and transition over to some of the questions. For you, Thomas, we have actually tons of questions rolling in right now, so we'll get to as many as we have time for today, and then our plan will be to follow up with like a blog post after the webinar with anything that we don't get answered. So Michelle K. would like to know, why isn't everybody enrolled in Medicare Advantage? Why do some people who are eligible not enroll?
That's a great question, and I think there are a lot of policymakers who would like to know the answer to that question. I think, in part, just the term Medicare has a great brand name, and I think people may be a little bit skeptical about thinking that they're going to be leaving the Medicare program and going to a private insurance company. That might be part of the reason. I do think, though, however, that we are very close to a tipping point where Medicare Advantage is going to be the predominant way for people receiving Medicare benefits probably in the next 2 to 3 years. It took a long, long time to get there. In part, I think that's maybe because the payment system didn't really work all that well until the changes that were made in the MMA in 2003 and the HCAOA in 2010. But I think the payment system works pretty well now, and I think we're going to start to see that those numbers change fairly quickly.
Yep, absolutely. Subhashri S. Is curious, what criteria are used to give a star rating to an MA plan?
CMS publishes essentially a domain with multiple, over 100 elements of the domain. And it's everything from how quickly does a customer service rep, answer the telephone at a plan's 1-800 line, to the number of hospital readmissions, something that we might traditionally think of as quality, like, for example, hospital readmissions, treatment of individuals with chronic illness, to things like how quickly does someone answer the phone, how quickly does an appeal, if a beneficiary appeals a medical necessity denial, how quickly does that appeal get resolved, things like that. There are well over 100 domains that are used to assign star ratings. And there's some type of statistical process that I do not pretend to understand how the statistical process works, but CMS uses the information from those domains to assign star ratings to plans. And I would say probably most MA plans in the United States are 3, 4, or 5 stars. If a plan is 1 or 2 stars, they're not gonna stay in business very long.
Got it. So actually, multiple people had this question, so it's not coming from just one person. They would like to know how a home care agency, a non-medical home care agency, knows if they're eligible, and how they obtain certification if they need to do that.
I would say that the best pathway forward would be for a non-medical home care agency to reach out to MA plans that are servicing the geographic area of the home care provider.
Okay, got it. Treff H would like to know, why wouldn't a person choose MA versus Medicare FFS?
I think that's a version of the first question, which I thought was a great question. And I think it's just because people traditionally are familiar with the brand name Medicare, and Medicare Advantage seems like something different or something new. But I also think that over time, very shortly, like in the next 2 or 3 years, there's going to be a tipping point where most people get their benefits through Medicare Advantage. It's just taken a long time to get there.
Got it.
Grant H. would like to know, since payment to home care agencies would be made by insurance companies, does that mean we wouldn't need to obtain a Medicare provider number in order to receive payments?
Oh, that's a great question. So that's my understanding is that's up to the MA plan, but I would be shocked if an MA plan would ever agree to contract with a provider that did not have a Medicare provider number. I do not think that it is a requirement that an MA plan contract with only Medicare certified providers, but I would be shocked if an MA plan did not have that as its own independent requirement.
Okay, great. Kevin D. Would like to know, and actually multiple people had this question as well, is there a website or a way that we can look up reimbursement rates for our state?
Medicare reimbursement rates are between an MA plan and a provider are confidential, so that would not be disclosed.
Got it. Andrea G. would like to know what percentage of plans in 2020 are offering in-home support services?
The only statistics that I have seen are, can I just ask, you're going to make the slides available to everyone on the webinar, right?
Yeah, absolutely. This is being recorded, and we'll send out the recording. Usually we send it out within a business day. Okay,
so I would just refer to that slide that has the chart from Milliman. And then I would also say that AARP has a pretty good description of supplemental benefit offerings for the 2019 plan year. So if you just, actually, you know what, let me just do this right now. So I think if you just Google AARP, if you just Google supplemental benefits and Medicare Advantage, AARP's Public Policy Institute did a report in July of this year, and that report shows the number of plans. If you go to the PDF file that's on this website, it will show the number of plans and what benefits they're offering. So, for example, I'm just looking, I just Googled this really quickly. So just looking this super quick. So 47.1% of the new supplemental benefits in 2019 were nicotine replacement therapy, and number 2 was support for family caregivers. Number 3 was in-home support services. So you can find information online that talks about the supplemental benefits, but I would also just say that this is all going to change because the plan offerings for the 2020 plan year are being approved by CMS right now. And so I think there will be updated data probably by mid to late November. And so I think helpful to look at what's available online right now, but that information is going to get updated when plans start submitting data for the 2020 plan year.
Awesome, thank you. And we actually have tons more questions here, but I'm probably going to keep it to maybe 1 or 2 more, just for the sake of everybody's time. And then, like I said before, we're recording this. We'll follow up with a blog post after. Another question from David C. And I think this is one that's important for everyone because we're all kind of coming from different levels of understanding about this. Can you expand and clarify how you see home care agencies participating in Medicare Advantage, since most of their clients receive non-medical in-home care?
I'm sorry, can you, so how a home health agency would participate in Medicare Advantage?
Exactly, yeah.
Yeah, so, sorry, I cut you off.
No, you had it right, yep.
So I would say that is between the MA plan and the provider, and the provider just needs to approach the MA plan and try to work out some type of contractual agreement so that the provider can provide benefits for the plan enrollees.
Perfect. Thank you so much. Okay. So one last question to round things out. Carl B. is asking, does CMS limit the amount of annual hours per policy in a given year?
I would say no, they do not, but the MA plan might.
Okay. Great. Well, actually, that was a quick one. So maybe we've got one more in us. Let's see. And I really do appreciate everybody's patience because there are a lot of questions coming in still. Let's see. Okay, so this is one point of clarification that many people have been asking about. This specific question is coming from Debbie Singh, but multiple people asked a version of it. They want to know, do home care agencies have to partner with licensed agencies? And do you absolutely have to be licensed as a home health agency to be able to contract with an MA plan?
The answer to the second question is no, there's no CMS requirement. The MA plan may have a requirement, but CMS does not have a requirement that the provider be licensed as a home health agency, because some of the supplemental benefits that can be offered don't need to be provided by a home health agency, because so for example, providing respite care services for a family member of a home care beneficiary, that doesn't need to be provided by a licensed home care agency because CMS doesn't regulate that. And I'm sorry, I answered the second question, but what was the first question?
So that actually, I think you answered both of it. The follow-up kind of piece to that is whether or not a agency, regardless of whether or not they're certified by CMS or not, whether they need to have licensed home health aides providing services, or if potentially they could be non-medical, unlicensed caregivers.
They can be non-medical, but there has to be some nexus between the person providing the services and whatever state licensure may be. So, right. So for example, some states license personal care aides. Mm-hmm. And so to the extent that an MA plan contracts with a personal care aide in a state where licensure is required, they have to be licensed under state law, but they don't have to be licensed as a Medicare provider.
Right. Got it. Awesome. Thank you so much, Thomas. And we're pretty much at the hour here. So I'm going to say, again, thank you so much for all the questions. We'll follow up in the coming weeks.
Yeah, I want to say thank you for the questions also. They were great questions.
Yeah. Really appreciate your participation and sharing all this information today with us, Thomas. It's great to have you. For anybody who would like to stick around for a couple minutes, I've got a special offer for you, and I'm going to talk a little bit about CareAcademy. So I'm going to go ahead and get my screen shared. If y'all give me just one moment. Perfect. So a quick special offer for all of you who are sticking around with us. We have a amazing free trial option on our website. As I said before, CareAcademy, one of the ways that we help people in this time of learning about Medicare Advantage is that we have training which has been proven to help shape outcomes, and so I'd love for you to try CareAcademy for free. Here's the website and, of course, our contact information if you need to get in touch with us. The free trial is right there. It's available. So I'd love for you to start using CareAcademy and see some of the outcomes that you get. It's a great way to talk with your MA plan, your local MA plans, about what you're doing to impact the outcomes of your client cases that you're working on. So with that, I'll just talk just a little bit about CareAcademy. If you don't know too much about us, right now we are the #1 provider of online training. We provide mobile first online classes, and what that means is we actually designed our classes specific to be taken on a mobile device, a smartphone, a tablet, though they can be taken on any device at all. We're the first online training provider to create a portable record standard for caregivers. What this means is that your caregivers are able to take their training with them, so that way you never have to retrain any new hires that you've taken on. They'll just be able to send you those records easily. We have over 60 hours of classes that are all state-approved topics for meeting your compliance requirements, upskilling your caregivers, as well as meeting CE requirements for those CNAs and other licensed frontline staff members. We have an at-a-glance dashboard that lets you see exactly what's happening with your employees without having to pull a ton of reports. You can just log in, see exactly what you need. And then, of course, we have an amazing customer support team who is available 7 days a week. They're available chat, phone, and email. They support every level of user. You don't have to be a manager to call our support team. Caregivers are, in fact, encouraged to call our support team directly, so that way we can help them if there is anything that they need assistance with. So it's just a little about CareAcademy. I'm going to go ahead and demonstrate how the classes are used from the caregiver perspective and then from the management perspective. This will be really fast. So if anybody would like to get a longer demo, just reach out to us, to our sales team. We can help you out with that. So I'm going to go ahead and log in as if I were a caregiver to the classes. What's great about CareAcademy, like I said, it was designed for caregivers to take on any mobile device, but most people are using an iPhone. We do use Google Analytics, and we know that to be the case even for our caregivers that are taking our classes. I'm going to log in as a what's great also is when a caregiver first gets started with CareAcademy, they will get a text message and an email, depending on what contact information you give to us. So they can just click on that text right on their phone and go straight to this page to log in. They set their own password and they can manage that. As you see here, this is the caregiver dashboard. So this is where the caregiver is able to manage the training that they're taking at all the different agencies they work for, which use CareAcademy. So the days of caregivers losing a certificate of completion are over. When all the different offices or agencies that a caregiver works for use CareAcademy, all of those records will be centralized for the caregiver so they can easily get an old certificate and send it over to you. So if they just took infection control a couple weeks ago at a different agency, you don't have to pay for them to take that class all over again if it's part of your state requirements to give that training. They can just send their certificate and you know it's from a valid source. So that's what you're seeing on this page. I'm going to go ahead and take classes as if I were for working for this agency right now. As you can see here, the way this is set up is specific to using a mobile device. So it automatically reorients depending on what device you're using. You scroll just like you would as if you were on Facebook. You click the start or resume button to take a class. I'll go ahead and start this class that I was already in. The majority of our classes are video-based, but there are several different types of activities within each of the classes. When a caregiver is going through these classes, they will watch the videos, participate in the activities, and then at the end they'll complete a test where they need to get an 80% or better to be able to pass. The videos themselves have a couple different types of components within them. Some of the great things that are in these videos are scenario-based training, where we put a story in the context of a real-life situation, and we show the caregiver the right way and the wrong way. And then, of course, there's also a little bit of lecture from experts, like the video that you're seeing here. All of these videos were created within the last couple of years, and so they're all very up to date with not only with the information, but with the style, the ease of use. And that actually makes it so that way CareAcademy right now has a 90% class completion rate of the classes started, which is really, really phenomenal, because it means when a caregiver actually starts taking these classes, they're finishing them, they're enjoying them, and it has the benefit of course, getting the training done that you might need for your compliance as well. You'll also note that I'm not able to move forward through the classes until I've completed each section, so they are quote-unquote gated. So they can't just skip through. So that's an example of the caregiver side of the system. I'm going to go ahead and give you a really quick glance at the management side of the system. So what you're seeing here on the screen is an overview of the multi-agency dashboard. So this, if you manage multiple locations in your business, this allows you to be able to easily see what's happening at each of your different locations. You can see the number of caregivers activated and deactivated, initial and annual training that's overdue soon or already overdue. And then, of course, you can also see caregivers, which the training hours of caregivers and inactive caregivers. This is a really helpful insight. This is how many caregivers have not logged in for more than 90 days. So those are the people who are at risk within your organization, folks that are not really engaged, and you might want to ping them. I'm going to go ahead and go into one individual location here. So this is just one individual location, happens to be in California. And so this is what the typical, agency owner or manager would see when they log into CareAcademy. It shows you at a glance a snapshot of what's happening with all of your employees. So you don't actually have to go in and pull a report if you don't want to. You can just high level see the green bar means, yeah, they did that. That's done. I'm good. And then the annual training, I can see here this caregiver has only completed 33% of her annual classes. So if I want more information, I can really simply just click on her name, and then I can get the details. So now I can easily see, okay, here's what's in progress, here's what's not done yet, and it gets those certificates of completion for that one specific training program that she's working on right now. So that's a really high-level overview of the main at-a-glance dashboard. The really important thing to know about CareAcademy is that we have tried to build in all the automation that you could possibly need for your agency. So when you sign up with CareAcademy, your dashboard is programmed for your state. So we already know what your compliance requirements are in your state, or if you don't have compliance requirements, we know that as well. And so your dashboard will be already set up with the curriculum that is specific to that state. So that way, all of your caregivers get the right classes at the right time, right where they are on their phone. So they don't have to go searching around for it. It's just exactly what they need, already programmed out to be assigned to them, and they get reminded about it. So we have automatic text messages which go out based on the schedule of the training that meets your state requirements. So let me demonstrate to you as well on this curriculum page here. If I were to try and change the curriculum in a way which was against your state requirements, I would actually get a warning. So we have it set up to the level where you don't actually have to remember all of the details of your requirements. We'll give you a reminder if you try and do that. Then, of course, you can make any of your own groups of caregivers and different curriculum tracks on top of your requirements that you might want. So for a demonstration of that takes a little bit longer to kind of go through in terms of setting up your training dashboard above and beyond the state requirements. So I'd encourage you to come talk with our sales team, get a demonstration personal to you and your organization so we can go through all the different options and see how it would be set up for your business. I'll just leave you with one last piece about the dashboard here. The message log is where you are able to see and track all of the different reminders that we are sending to your team. So we're trying to take a lot of the burden of compliance off of your plate. And when you want to see what we've been sending out to remind your caregivers, you can see that right in this message log. You can also text your caregivers very easily as well, but we want to do a lot of that heavy lifting for you. So with that, again, like I said, I'd encourage you to check out a free trial and certainly get in touch with our team here in the office. We'll be happy to give you more information about how we can help your agency, your state requirements specifically, and talk a little bit more with you. So again, thank you so much, everyone, for joining today. It was a pleasure talking with you. It was a pleasure having Thomas on. Thanks to HCAOA. And we'll be looking forward to speaking with you soon. And actually, thank you so much for the reminder. I'd love to ask, for anybody who's still stuck around, would you like us to reach out to you and follow up with you on the phone, either you or your manager? Just say yes there if you'd like us to do that. So, of course, you can also check us out on our website as well. But if you want us to follow up with you, just click yes, and we will go ahead and do that. Leave that open for just a couple minutes for everybody to respond. All right. Well, thank you again, everyone. Really a pleasure. We'll be looking forward to getting in touch with everybody who would like that. As we mentioned, we'll be sending out the recording shortly and following up on all the other questions that we weren't able to get to in this 1 hour session. So, thanks everybody, and I hope you have a wonderful afternoon.